So let's just push it. Yeah.
Okay. What does that do? Does that turn it on?
You're now on. You need to get a little closer.
Okay. I was on the order, unless they changed.
This hearing will come to order. Today we have a hearing entitled Insured But Not Covered, the Problem of Uninsured. The Chairman, the Ranking Member, and Chairman Emeritus will be recognized for a 5-minute opening statement. Other members of the subcommittee will be recognized for 3-minute opening statements. I will begin. A few months ago, our subcommittee held hearings on the health industry practice of terminating coverage after a policyholder becomes sick and files a claim. In our investigation, we learned that if your insurance company believes you have an illness that may be costly, it will go back and re-examine your application for health insurance to find any excuse to cancel your coverage. As health insurance industry executives brazenly told us, this practice, called rescission, will continue until there's a national health care coverage for all Americans. Today we continue our investigation of the private health insurance market, focusing on the underinsured. An underinsured person is one who has health insurance coverage, but the policy does not adequately cover the health care costs or high medical expenses. Underinsured individuals traditionally have high out-of-pocket expenses because of high deductibles and co-pays. In some instances, people are uninsured because they can only afford a basic policy. In other instances, policyholders believe that they have adequate coverage, only to find that there are limits buried within the policy, such as annual caps on the amount the insurance will cover, or limits on the number of times the policyholder can receive certain services or treatments. Regardless of how you find this financially fragile group, the sad consequences of being uninsured can be devastating, lead to financial ruin, bankruptcy, and making medical decisions based on cost rather than care. As the cost of health insurance skyrockets, more and more Americans are finding they can only afford bare-bone policies, leaving them one illness, one accident away from bankruptcy. According to the American Medical Association study in 2007, 62% of all bankruptcies filed in the United States were related to medical costs, and 78% of these filers had insurance. Many of these now bankrupt individuals were well-educated, owned homes, and had middle-class occupations. Unfortunately, they were underinsured, and their health insurance did not cover their medical costs, forcing them to declare bankruptcy due to mountains of medical debt. Still, health insurance continued their unconscionable increase in premiums. Between 2000 and 2007, the annual family health insurance premium in Michigan rose 78%, while wages rose just 4.6%. I am currently receiving emails and letters from constituents reporting 22 to 40% premium increases in their individual health insurance policies. The average family health insurance policy now costs $13,125, which is, by the way, 34% of the median household income in my congressional district. The Commonwealth Fund, which will testify today, recently reported that as a result, more families are experiencing medical problems or cost delays in getting needed medical care. In 2007, nearly 2/3 of U.S. adults, 116 million people, struggled to pay their medical bills, went without needed care because the cost, were uninsured for a time, or were underinsured. Our first panel of witnesses will put a face on the frightening statistics found in the Commonwealth Fund report. Catherine Howard was diagnosed with breast cancer at the early age of 29 and survived to tell her story. Being young and healthy with a limited income, Catherine chose a low-premium, high copay health insurance that left her in financial shambles after her breast cancer. At the time of her illness, she was earning just $20,000 a year, but her outstanding medical bills were $40,000, and Catherine was unable to work through her surgery, chemotherapy, and radiation. To her credit, Catherine did not declare bankruptcy and is paying $1,800 per month on her outstanding medical obligations. David Null will speak of his family and his daughter Tatum, who at the age of 7 was diagnosed with liver failure. David bought health insurance for his family to cover emergency situations, not a policy to cover head colds. Still, when Tatum was on life support and needed a life-saving $560,000 kidney transplant, David learned his emergency policy would only cover between $30,000 and $40,000, and the hospital was demanding a $200,000 deposit before they would proceed with the transplant. Being underinsured left Tatum fighting for her life and David without a hope or a prayer. Children's hospital officials helped the Nulls qualify for a government-run, government-sponsored Medicaid health care program, and the entire hospital bill was retroactively covered. The catch is the Nulls could not earn more than $1,614 a month, or they would lose their Medicaid coverage, which paid for Tatum's medication to prevent organ rejection, which can cost thousands of dollars each month. Nathan Wilkes will tell us about his employer-provided health insurance with $1 million limit for each family member. Unfortunately, $1 million does not go very far when his son was diagnosed as severe hemophilia. Even though the Wilkes have paid up to $25,000 in a single year for out-of-pocket costs, Mr. Wilkes is unable to get a policy that will adequately cover his son's medical expenses. Now, on his third insurance policy, Mr. Wilkes does not know how they will be able to afford his son's life-saving medical treatments. Each of these individuals and families did everything right, worked hard, purchased health insurance, paid their premiums, but were still left in financial ruin. We will also hear, as I said, from Sara Collins of the Commonwealth Fund. She will discuss their study on how a number of uninsured have dramatically increased over the last few years and how now 2/3, 116 million of U.S. adults struggle to pay their medical bills, like the Nulls, the Wilkes, and Ms. Howard. Stan Brock is the director of the Remote Area Medical Foundation based in Nashville, Tennessee. He has spent his lifetime coordinating with physicians, dentists, nurses, and other health providers to provide free health services to the uninsured and underinsured Americans. Mr. Brock will provide his insight and experience on how more and more Americans are showing up at his foundation seeking basic health care because their insurance policies will no longer cover their health care needs. Each of us know a family member, a relative, a friend who did not go to a doctor when sick, who skipped a dose of medication or failed to fill a prescription, intentionally missed a medical test or a follow-up appointment, or did not see a specialist when needed because they could not afford the service, the medication, or the test. I would hope every American will now take time to look at their policy and really understand what medical conditions does my policy cover or not. What is your copay? What is your potential for out-of-pocket expenses? Do you have a lifetime cap of dollars or services with your insurance company? The U.S. House will soon vote on H.R. 3200, America's Affordable Health Choices Act of 2009. H.R. 3200 does not allow insurance companies to rescind your policies when you are sick. It does not have a lifetime cap, and it will cover all Americans. Only the passage of meaningful health care reform, then and only then, will 2/3 of all adults not have to worry about how to obtain medical care for their families while remaining financially secure. I would next turn to the ranking member of this committee, Mr. Walden of Oregon, for an opening statement.
Thank you, Mr. Stupak, for convening this hearing. As the Congress continues to debate ways to reform the health care system, the subject of this hearing should remain a top priority. As we will hear today, insurance does not always cover the complete cost of an illness or injury. This nagging question, if I get sick, will I be able to afford treatment, worries many Americans. Today, as we've heard from the chairman, we'll hear from several people who thought their insurance would be there when they needed it, and it was not. David Null faced every parent's nightmare. His daughter fell into a coma as a result of a liver failure and needed a transplant within days. He thought his insurance would cover everything, but instead the policy only covered $25,000 of a $561,000 surgery. In order to pay for the transplant, Mr. Null had to turn away work in order to qualify for Medicaid. Catherine Howard thought she had quality insurance. She'd been happy with the coverage she had under a previous employer, so she purchased an individual policy for herself when she started working on her own. After being diagnosed with breast cancer, Ms. Howard learned that she would be paying approximately 30% of the treatment costs. Eventually, she would end up $100,000 in debt. And Nathan Wilkes also thought he had great insurance through his employer, yet his newborn son's illness required a substantial amount of care, and Mr. Wilkes' son Mr. Wilkes soon learned that his health care policy had a cap, and that cap would eventually cut off care for his son. Meanwhile, the premiums for his health care were beginning to rise substantially. The increased cost of care for his son was also driving up the cost of premiums for his employer. I want to thank our three witnesses on this panel today for testifying and making your stories known. Their experiences, yours, are incredibly personal, and I want to commend you for agreeing to testify before this committee. We will also hear from Sara Collins of the Commonwealth Fund and Stan Brock from the Remote Area Medical, and I thank them for their testimony as well. Beyond the astronomical costs the underinsured face, this committee will also hear about other problems in the industry affecting our witnesses. Mr. Null will testify that he was misled by the company's salesperson when he purchased the policy for his family. He considered himself a savvy purchaser of insurance, and he would research plans, purchase the ones that had offered him the best rate and coverage, and switch to a new insurer if a better deal came along. He told the insurance salesperson that he was looking for a policy that would cover the big "oh no." Instead, he was sold a policy that capped hospital stays at $25,000, which in his daughter's case turned out to be only a few days. Whether the salesperson's claims about Mr. Null's policy were fraudulent or mere sales puffery does not matter, because we can all agree that when selling something as important as health insurance, the American consumer needs to be protected from both fraudulent statements and over-the-top representations. Two of the witnesses today are here to discuss the health care problems affecting their children. While these children are covered under family plans today, in the future their pre-existing condition could limit the ability to obtain insurance themselves. Pre-existing conditions affect many Americans, and I believe this committee and Congress need to work to make sure access to quality and affordable health care remains our top priority. We cannot ignore these problems, especially in light of rapidly increasing health care costs in the United States. Over the last decade, employer-sponsored health insurance premiums have increased 131%. Recent studies have found that in 1 year, as many as 62% of all bankruptcies were linked to medical expenses, and 1.5 million families lost their homes due to these costs. I again thank our witnesses for joining us, and I thank you for holding this hearing, Mr. Chairman. On a personal note, I would say that my wife and I were parents to a son who was diagnosed with hypoplastic left heart syndrome. We faced many of the challenges you faced when it came to trying to deal with the transplant that he needed. Tragically, he passed away before he could have that transplant. But we faced many of the same issues that you face and dealt with them as a parent. So I'm deeply sympathetic to what you're encountering. Mr. Chairman, I'd like to remind this committee that on June 25th of this year, Ranking Member Barton and myself sent a letter to both you and Chairman Waxman requesting additional investigation and hearings to follow up on our June 12, 2009 hearing on GM and Chrysler dealership closures. Interest in this subject was intense, as you know, at the time, and I hope this committee will not shy away from its oversight obligations on this matter, especially considering how the American taxpayer is now substantially invested in these companies. And I again urge you to hold additional hearings, including inviting the auto czar to testify, and making sure that those who did testify provide us with the documents and emails that they said they would when they testified. So I've got another copy of that letter, Mr. Chairman, for both of you, and I hope you'll take a look at it and afford us that opportunity to do the oversight that this committee has so proudly done in the past.
Thank you, Mr. Walden. Mr. Waxman, Chairman of the full committee, opening statement, please.
Thank you very much, Mr. Chairman. I want to commend you for holding this hearing. The primary purpose that people have in buying health insurance is to protect them when they get sick, and not to have catastrophic costs of health care drive them into bankruptcy. You should not have to go broke because you get sick, so people buy insurance to protect themselves. Yet we're finding out in the investigation this committee is doing on private insurance for health care that there are a lot of schemes that the insurance companies have not to pay. We had a hearing earlier this year on how there's a thing called rescissions. Now, we all have heard that the insurance companies don't want to cover you if you have pre-existing medical conditions, and that means a lot of people can't get insurance even if they could afford to pay for it. But what some of the insurance companies have been doing is that when you get sick, they go back and look for some error on the application and then decide that they're going to rescind the agreement and leave you just high and dry without the coverage. Today we're looking into another topic as we examine insurance company schemes. And this one is the underinsurance that people don't realize that they may face when they get sick. In recent years, we've been looking at a lot of different problems, but we looked at rescissions. Now we're looking at underinsurance. But as we examine insurance practices, our committee has been looking into business practices in the small group market. And I'm looking forward to the hearing on this topic next week, where we'll learn more about the challenges facing small businesses that seek to cover their employees. And they want to get quality, affordable health insurance for their employees, but the insurance companies will not cooperate and keep that insurance available to them.
Understand.
But today's topic is underinsurance. And in recent years, health policies have been costing more and covering less. The average cost of a family's premium has risen 131% in the last decade, while average wages have risen less than a third of that amount. Meanwhile, benefits are declining, and employers are asking workers to shoulder more of the burden by paying higher premiums or other out-of-pocket costs. Well, insurance companies ask you to pay more, but then there are a number of other ways they come up short. They can have caps or limits on the amount an insurer will pay for an individual's care over a lifetime or in a single year or for particular service. And other plans exclude coverage for certain pre-existing conditions or limit coverage in other ways. So in other words, what we're seeing are insurers increasingly shifting the risk to the individuals through greater cost sharing, such as higher deductibles, co-payments, or co-insurance. The risk should be borne by the insurance companies. That's why we're buying insurance in the first place. So with skyrocketing health costs and skimpier coverage, we now see the ranks of the underinsured growing. In 2007, there were 25 million underinsured Americans, a 60% increase from just 2003. This is in addition to the 50 million people who are completely uninsured. Underinsurance is on the rise among both low and middle income Americans, and it often leads to medical debt that empties saving accounts and ruins credit scores. For many, the medical debt is simply too much to bear. And a recent study found that 62% of all personal bankruptcies are related to illness or medical bills. Underinsurance has grave consequences for families' physical as well as financial well-being. I look forward to our hearing today from witnesses who have struggled with steep medical expenses despite the fact that they paid for health insurance. And I want to thank Ms. Howard, Mr. Null, and Mr. Wilkes for agreeing to share their stories with this committee. And I also look forward to hearing from Sara Collins of the Commonwealth Fund and Stan Brock of the Remote Area Medical Volunteer Corps about the growing problems of underinsurance. This hearing comes at a time when Congress is struggling with health care reform. One clear reform has to be insurance reform to stop these medical insurance practices from going on. People shouldn't be fooled into thinking they're covered and then find out when they need their health insurance coverage the most that they are in fact underinsured. This is one of an ongoing series of hearings from this committee. I think it's important that we have these hearings in order to drive forward legislation to stop these kinds of practices from going on in the future. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. Mr. Barton, opening statement, please.
Thank you, Mr. Chairman. Thank you, Ranking Member Waldron, for holding this hearing. I'm going to put my official statement in the record, just speak extemporaneously. We obviously, on both sides of the aisle, believe that it is time to reform our health care system, and it is just as obvious that a part of that reform should be insurance reform. Myself and Mr. Green and Mr. Stupak and others offered an amendment at the additional day of markup several weeks ago where we put a transparency amendment in for the health care system, which would include insurance companies. And in underinsurance, there's nothing more important than providing transparency so that individuals know what coverage they're really getting, and that companies are upfront about what coverage they're providing and what those caps are before the fact. It's terrible to find out after the fact, like Mr. Null found out that his what he thought was a catastrophic policy really wasn't, or it wasn't in such a way that it covered his daughter. So I think this is a good hearing. It is a part of the record that needs to be made. I do want to say, in response to what Chairman Waxman said, that in the overall effort for health care reform, I do not believe a solution is a mandatory coverage requirement for individuals, because some individuals will be impacted in a very negative way by being mandated that they have to carry it. If we can get transparency and get competition and get reform across the board, then if you're not covered at work and you want a private plan, and we set up some of these pools, you'll be able to choose from plans and know what you're getting. But I have nothing but respect for the witnesses today that are going to give their case histories, because they are very moving, and I hope that a good thing will come out of this that will create a bipartisan consensus on some of the things that need to be done to reform the disingenuity in the private insurance market for plans like these folks have had to bear. Thank you, Mr. Stupak.
Thank you. For 3 minutes now, we hear from a gentleman from Massachusetts, Mr. Markey, for an opening statement.
Thank you, Mr. Chairman, and thank you so much for having this very important hearing. As we consider the urgency of expanding health care coverage and transforming our sick care system into a health care system in our country, this question of the underinsured is right at the heart of the matter, because there's an estimated 25 million Americans who are insured, but they are underinsured at the same time. And let's just focus in on this problem. Medical bills are the leading cause of personal bankruptcy in the United States today. 60% of all bankruptcies are because of medical bills. 60%. And of the 80% of people who went bankrupt because of their medical bills, 80% of them had insurance, and they still went bankrupt. Insured, but not covered. Now, I recently received a letter from a constituent in my district. He returned home from open heart surgery and found a bill from the hospital informing him that his insurance company had denied coverage for the anesthesia used during the operation. They deemed the anesthesia, quote, medically unnecessary, and demanded $10,000 for the anesthesia. Now, he asked me, did the insurance company expect him to take a swig of whiskey and bite a bullet while they cut open his chest? Well, unbelievable, but they did, and they sent him the bill for $10,000. Insured, but not covered. This is how we get 60% of all bankruptcies in America related to medical bills that people receive. It is unacceptable that patients must fight their health insurance companies for coverage while fighting disease at the same time as they are insured. It is unacceptable that parents have to help a child overcome a crippling illness while struggling to overcome crippling medical debt by postponing necessary treatment, skimping on food, and even exhausting their savings so that they can qualify for Medicaid. It is wrong for health insurance companies to deny coverage for critical treatment when families need it the most. And I am pleased that the health reform bills that we are considering will make tremendous progress in this area. The plight of the underinsured and the steady creep of the underinsured into the ranks of the middle class shows that health care affects each and every one of us, and now is the time for us to fix this sick care system and turn it into a health care system for all Americans. Thank you, Mr. Chairman, very much.
Thank you, Mr. Markey. Ms. Blackburn, for opening statement, please. 3 minutes.
Thank you, Mr. Chairman. I want to welcome our witnesses and thank them so much for giving their time and for being here to share their experiences. And I especially want to welcome these two beautiful young girls that are sitting on that front row. We are thrilled that they have taken the time out. I bet it's a day out of school. And we hope that they see this as a learning experience. Mr. Chairman, I do thank you for the hearing today. We are all concerned about coverage for pre-existing chronic conditions. We are so concerned about the rescission issue. I think that where you're going to see some differences is how we approach the badly needed insurance market reforms that are out there. I'm one of those that wants to keep things patient-centered, patients first, free market-oriented, and I would like to see more competition in the marketplace as we seek to address this, allowing purchase of insurance policies from across state lines so that families have more options and more choices. Now, in Tennessee, where I'm from, health savings accounts are very popular. We would love to see the contribution and allowance limits there enhanced and to see incentives for individuals with healthy lifestyles. Liability reform has already been mentioned this morning. The practice of defensive medicine does drive up costs, but it also plays in sometimes to that rescission issue, and we're aware of this and seek to address that and to address it in good faith. I want to give a special welcome to Mr. Brock, who is here. You're going to love hearing from him, and I commend him to my colleagues. The RAM program is one that we're very pleased with in Tennessee. Quoting from page 2, second paragraph of his testimony, I want to highlight one thing. The greatest impediment to RAM programs is regulation in 49 states preventing willing practitioners from crossing state lines to provide free care. Now, in Tennessee, we have addressed this issue. Dr. Burgess has talked about that issue. It came to light after Katrina. I am looking forward to hearing from him and to welcoming them today, and I yield back the balance of my time.
Mr. Welch, opening statement, please.
Thank you, Mr. Chairman and Ranking Member Walden. And the stories that each of you told really summarize, I think, what can only be described as the failure of the American health insurance industry. The health insurance industry, in fact, has served its own interests very well, but it's failed the American families and consumers. It's failed the small businesses that pay the premiums. It's failed our taxpayers. It's failed our doctors and our nurses and the healthcare providers. What it has done is served its own interests very well. The CEOs, some of whom make $24 million in a year, Wall Street analysts who cheer every time the medical loss ratio goes down, meaning that each of every premium dollar has less spent on health care and more spent on dividends, on CEO salaries. It served its own interests very well because essentially it's based on a model that you've heard described here. And that model says that if you're healthy and you're wealthy and you're unlikely to need it, we'll insure you and we'll keep increasing your rates. But if you're sick or likely to get sick, if you're older, we won't insure you, or if we do, we'll make a policy so confusing and laden with so many loopholes that you won't get much benefit for the insurance that you thought you had. As Mr. Markey said, you're insured, but you're not covered. And just another example to add to the laundry list here of horrors. This is much smaller and much more mundane, but it shows just the Alice in Wonderland world that the insurance companies operate in. We have a woman from Milton, Vermont, Cheryl, who had a policy that she thought had covered wellness screening, and she got a colonoscopy and was told it would be covered. But lo and behold, a colonoscopy, in fact, diagnosed diverticulitis. And the insurance company said that procedure was no longer about wellness, it was diagnostic, and that was not covered, and they made her pay the $1,000 bill. I mean, those days we have to put behind us because the insurance company has had its chance and it's failed. And when a person buys insurance, when a small business pays a premium to cover its workers, those folks should have assurance that they're getting something real, health care insurance and coverage when they need it. Thank you, Mr. Chairman, for this very important hearing, and I yield back.
Mr. Burgess for an opening statement, please. 3 minutes.
Thank you, Mr. Chairman. I'll abbreviate my statement and submit it in its entirety for the record. I do want to thank you for holding the hearing today. I really believe this is a twofold problem. On the one hand, we have hardworking Americans who do the right thing day in and day out. They go to work, they buy health insurance, and then when they get sick, their medical insurance does not cover their bills. If they work harder and make tough choices in other areas of their life, they still struggle to pay their medical debt. As I did my town halls this summer, as many of us did, the one thing I heard over and over again, people are genuinely frightened of what Congress is going to do to health care in this country, and they're probably justified in that skepticism. But the one thing that everyone seems to agree on is the issue of excluding someone from insurance coverage because they've had a tough medical diagnosis, or the issue of excluding someone or the insurance rescission when a tough medical diagnosis is rendered for someone who is already insured. Those are the processes that have to stop. Nothing infuriates people more than thinking that someone has played by the rules, paid their dues, and then when they actually need the service, they find it's withdrawn from them. People who are responsible and do what it takes to provide for themselves or their loved ones are, in fact, to be commended and are not to be put in positions that are just absolutely untenable. And we do have the issue of insurance as a whole. You do want to protect people from those contingencies in life from which no one can anticipate and no one can reasonably be expected to save the amount of money that would be required to pay for some very, very tough diagnoses. The cost of care has gone up significantly. There's no question there's the advancing complexity of what we're able to do. When I think of some of the saves that I saw during my medical career that late in my medical career we would have never seen in the beginning of my medical career, those things they're important, and we certainly don't want to, in our zeal to cap costs, we don't want to cap innovation or remove the innovation that has really set American medicine apart from medicine that's practiced in almost any other country. Mr. Barton referenced transparency. 3 Congresses ago, I was charged by the Speaker of the House, who was then a Republican, to work on the issue of transparency, and I introduced legislation that year. It finally did find a place in H.R. 3200 as it left the committee this year in September. I don't know if it will survive the cutting room floor over in the Speaker's office, but I'm hopeful that it will, because transparency is important. Another provision that was in the bill that I partnered with Mr. Dingell on was the issue of internal and external review boards. When you have whether it be a public option or a private insurance company, if they deny the coverage, a patient ought to have the right of appeal. They ought to be able to appeal to not just an internal review board within the insurance company, but an external review board as well. And that's true whether it's Aetna, Cigna, United, or a new robust public option that's instituted by the United States Congress. If care is denied for whatever reason, patients ought to have the right of appeal. It doesn't mean that we need to be spelling out everything that is involved in someone's health care. And I told the chairman I would abbreviate my statement and submit the balance of it for the record, and that's what I will do. I do thank the witnesses for being here today. This is an important part of the process. I will just say I think we would have done the American people a service if we had concentrated on more how do you get around these nettlesome problems of pre-existing conditions and rescissions without resorting to mandates which really have no place in a free society and only ultimately enrich the insurance companies. I'll yield back the balance of my non-existent time. Thank you.
Non-existent. Your summary was longer than your statement. Let's go to Ms. Christensen, please.
Thank you, Chairman Stupak, and thank you, Ranking Member Walden, for holding this hearing, both of you. It's important to highlight why health care reform and providing affordable, secure insurance coverage without caps to everyone is so critical, not just to the physical, but also the economic well-being of our families and our country. I also want to welcome the witnesses and their family for being here this afternoon and to share those very personal, very painful stories and provide more insight on the need for affordable, adequate insurance coverage. Underinsured Americans far too closely resemble the uninsured, but they're often the forgotten faces of the healthcare debate. Currently, 25 million Americans, as we've heard, cannot afford to pay the gap left by weak insurance coverage and large medical bills. And I was surprised to learn recently that even end-stage renal disease patients may find themselves uninsured, even though they're covered by Medicare. Underinsurance is also a contributor to health disparities. Despite the presence of full-time workers in the vast majority of their households, racial and ethnic minorities are disproportionately underinsured or lack coverage altogether and therefore less likely to receive quality health care. It causes a vicious cycle, as we'll hear, in our healthcare system that forces far too often people to forego medical treatments or prescriptions after they've already paid for insurance, resulting in poor outcomes. Even more traumatic is the fact that people don't realize they're underinsured until they're already sick and are facing those mounting healthcare bills. As we will hear, the average working family can faithfully pay their insurance premiums for years, but still go into medical debt or face bankruptcy when they get sick. A study released this summer by the American Journal of Medicine found that in 2007, a family filed for bankruptcy every 90 seconds due to excessive medical bills. If that's not shocking enough, 75% of those Americans already had health insurance. These are hardworking Americans that did not choose to wake up one morning with an injury or an illness that would not only deplete their productivity, but also deplete their bank accounts. The insurance companies have profited millions by ensuring that their policies are structured to defy the very purpose, as Chairman Waxman said, of having health insurance. So uninsurance and underinsurance is unacceptable, period. I look forward to passing and having the President sign a health care reform bill that ends it once and for all. And I thank you and yield back the balance of my time.
Thank you. Mr. Gingrey, opening statement, please.
Thank you, Chairman Stupak. First, I want to thank all the witnesses who joined us today, and I certainly look forward to hearing your testimony. As a physician who practiced medicine for over 30 years, one of the most important lessons I ever learned was that a medical solution for one of my patients was not necessarily the best solution for another patient. Each and every one was unique, but their needs, of course, were the same, ultimately, to get better. So as this Congress debates the nuances of health insurance reform and what type of insurance American patients should have, I believe that we must frame the debate in terms of what is best for the patient. With respect to the debate, H.R. 3200 and every other iteration of the Democratic majority reform proposals purports to create access to affordable health care, certainly a worthy goal, which I agree with. However, they do so by requiring that all health insurance products meet a one-size-fits-all mold through various federal mandates and, yes, cost-sharing limits. Unfortunately, studies have shown that these same mandates and limits on cost-sharing will drive up the cost of all health insurance products by as much as $4,000 a year for a family of four. In their plan, my Democratic colleagues, they seek to combat these cost increases with affordability credits. Unfortunately, in H.R. 3200, it does nothing to curb the cost of health care in this country. In fact, the CBO recognized that H.R. 3200 would actually increase the cost of health care in this country. So these affordability credits they give patients today will be worth less tomorrow, while the overall price of health insurance will continue to climb as it has done so for decades, has already been pointed out, only now at a much greater rate. One doesn't have to have a medical license to figure out that my colleagues are setting up a framework of unsustainable system. Where does this leave American patients? If we were to use the state of Massachusetts as an example, we'd find patients losing their health care benefits to offset the increased cost of care. Just this past June, 92,000 low-income patients lost their dental insurance because the state needed to trim the cost. 92,000 lost their dental insurance. Now, using the definition of underinsurance, I couldn't find it in the dictionary, by the way. Would those 92,000 low-income individuals who lost their dental benefits qualify as underinsured? If so, I might suggest that mirroring a health reform plan after the Massachusetts model could end up hurting those patients who truly need help in the long run. Mr. Chairman, while we do need reform to increase access to care for patients like those before us here today, we cannot simply slap the term reform on just any bill and assume that it will improve the quality of health care. In fact, the wrong kind of reform creates a system where these testimonies are the rule and not the exception. And I yield back.
Mr. Doyle, opening statement, please.
Thank you, Mr. Chairman, and thank you for holding this hearing on the issue of underinsurance at such a relevant time. For the last few months, Congress and the country have been engaged in a debate largely focusing on the 45 million uninsured Americans and often leaving out of the conversation the 25 million Americans that are underinsured. I look forward to our witnesses' testimony that will shine light on the problem of underinsurance in our country, a problem that unfortunately is growing at an alarming rate. In just 4 years, from 2003 to 2007, the number of uninsured Americans rose 60%. This is a problem that must be highlighted and will be addressed in the health care reform legislation that will go before the House soon. Underinsurance is when a policyholder believes they have adequate health care coverage, and then, when it's too late, they're proven wrong. When individuals buy insurance or are provided with plan options from an employer, the small print of their contracts is often overlooked, text which contains vital information about their coverage. This is exactly where people need to be paying the most attention, because it is here that often information on lifetime or even annual limits, co-payment requirements, treatment exclusions, and other limits on coverage is hiding. We all know we're supposed to read the fine print, but we also know that people don't always do it, which brings us back to the big picture. People don't know what they need to know until it's too late. I believe if you buy an insurance policy, you should know what you're getting and not have to hire a lawyer to understand it. Hidden traps, fine print, and at times misleading marketing ploys prevent the consumer from making an educated decision about their health coverage. And this is precisely why it is so important that we pass meaningful health care reform this year that will require insurers to provide a minimum set of benefits that will take care of patients' needs, limit out-of-pocket expenses, and prohibit insurers from imposing annual or lifetime caps on coverage. I look forward to hearing from our witnesses. Mr. Chairman, I want to thank you for this hearing today, and I want to thank the committee for highlighting this very serious problem. I yield back.
Thank you, Mr. Doyle. Chairman Emeritus of the committee, Mr. Dingle, for an opening statement, please.
Mr. Chairman, thank you. And I commend you for holding this very important hearing on an issue of great importance in our consideration of health reform benefits and health reform efforts. I want to commend you for the hearing, and I want to thank our panel of witnesses for being here today. We are grateful for your assistance, and I thank you. In our fight for health care reform, we focus on the 46 million Americans without health insurance. That's very important. But as has been observed already, underinsurance is an all too common problem that must also be addressed. In fact, by some estimates, 25 million Americans were underinsured in 2007. These 25 million people are paying at least 10% of their income for medical expenses, in addition to the cost of the premiums. In more simple terms, there are far too many Americans paying for insurance policies that do not cover the medical care they need, some of which policies are sold by practices close to fraud. Now, whether the underinsurance is caused by annual or lifetime caps or excessive cost sharing, or whether the policy doesn't cover the needs of the policyholder, the result is the same. Underinsurance creates an undue financial burden on far too many American families. In 2007, 28% of American adults reported carrying medical debt. Of the underinsured, 46% reported using all of their savings toward their medical debt. With statistics like these, it should come as no surprise that over 60% of personal bankruptcies are due to health care expenses. These numbers are staggering, but the personal stories are even more moving. Just this week, the Detroit Free Press ran a story about uninsured and underinsured Michiganders in my home state. One of the families profiled was the Hurleys of Canton, Michigan. The Hurleys have employer-sponsored insurance, but are forced to buy extra policies to cover the needs of their children. One, a 7-year-old with severe asthma, and another, a 10-year-old with skeletal disorder. Without the extra insurance policy, they could not afford the $50,000 spine surgery their son needs every 4 months. I am particularly grateful for our first panel and to them for having joined us today to tell their story of hardships due to underinsurance. I want them to know that their testimony is going to remind us and others of why it is so critical and so crucial that we pass comprehensive health reform legislation this year. Finally, I would be remiss if I did not mention the aggressive steps we take in H.R. 3200 to make underinsurance a thing of the past. This bill would, 1, remove all annual and lifetime caps. 2, limit the out-of-pocket expenses for everyone. 3, provide affordability credits for low and moderate income people to assist them with premiums and cost sharing. And lastly, it would enable all to know that all insurance policies provide a minimum level of health benefits to all Americans. And of course, we would see nasty little things like rescission of policies and pre-existing conditions. So we would see them end. So I hope today's hearings will serve as a call to action and remind us of the importance of the task before us. Thank you, Mr. Chairman.
Thank you. We have 2 votes on the floor. I'd love to get all the opening statements in before we break, if we could. So next, Mr. Green, please, for opening. Mr. Green.
Thank you, Mr. Chairman. I ask unanimous consent from my full statement be placed into the record. Underinsurance is when an individual actually has insurance, but their policy does not adequately cover their health-related expenses. It's such an important topic that I'm glad we're having this hearing. And last month, when our committee worked on, or has been continuing to work on, the health care reform bills, we addressed a great deal of that in H.R. 3200, as our Dean, Chairman Emeritus and Dean of the House said. Insurance premiums have risen steadily over the years, 131% over the past decade, and individuals are uninsured are paying at least 10% of their underinsured 10% of their income out of pocket expenses on top of their premiums. And according to the Commonwealth Fund, we'll hear with the second panel, 25 million Americans are underinsured in 2007, which is a 60% increase over 2003. All of us have constituents who call us and assist them with their insurance company policy problems, whether it's very low caps, in some cases in our district was $25,000, and either that or they do not provide coverage for certain services such as experimental cancer treatments, certain prescription drugs, and those have been denied coverage for a condition that is deemed pre-existing. That's why I'm so glad to have our first panel here today to talk about real-life experiences. But again, our committee's made a great step on H.R. 3200, and hopefully we'll get the vote on that sooner than later, and we can solve a lot of these problems, not only with the uninsured 47 million, but the millions of underinsured that we have in our country. And, Mr. Chairman, like I said, I put my full statement in the record. Thank you.
Thank you, Mr. Green. Ms. Schakowsky for an opening statement, please.
Thank you, Mr. Chairman. First, let me thank the witnesses. I read all your testimony, and I read it shaking my head. I've heard these stories before, but yet to hear the particulars are so disturbing, and I really look forward to telling those stories yourself. Here's one that was on the front page of the Washington Times yesterday. It says, Ian Pearl has fought for his life every day of his 37 years. Confined to a wheelchair and hooked to a breathing tube, the muscular dystrophy victim refuses to give up, but his insurance company already has. Legally barred from discriminating against individuals who submit large claims, the New York-based insurer simply canceled lines of coverage altogether in entire states to avoid paying high-cost claims like Mr. Pearl's. In an email, one Guardian Life Insurance Company executive called high-cost patients such as Mr. Pearl dogs that the company could get, quote, rid of, unquote. This, by the way, is meantime his parents are paying $3,700, have been, a month for his care. These are the kinds of horror stories that people face every single day in our country. And Mr. Null, you asked in your testimony, is that American? And I want to say that I hope at the end of 2009, you will be able to look at the kind of health care we provide Americans and your daughter Tatum and say, yes, this is American. And the kinds of things that we're going to do, I hope, are going to resolve the problems of all three of you and millions more in our country. We address the problem of high deductibles and cost sharing by giving individuals access to group rates through the exchange with annual out-of-pocket limits of $5,000 for individuals and $10,000 for families. We ensure that coverage is adequate, eliminating pre-existing condition exclusions and establishing a basic benefit package. We require that plans meet network adequacy requirements so that consumers, especially those with disabilities or ongoing health care needs, have access to the providers they need. 4, we eliminate annual and lifetime limits that leave health care consumers with huge medical bills when their coverage runs out, but their health needs continue. I believe that your testimony today will contribute to getting these kinds of reforms. I thank you, and I yield back.
Thank you, Ms. Schakowsky. Mr. Braley for opening statement, please.
Mr. Chairman, I want to thank you and Ranking Member Walden for holding this important hearing. I think all of us have learned that when health care policy is abstract, the American people run away. And the reason why your appearance here is so important to us and the entire country is because until health care policy becomes personal, people don't realize how broken our health care delivery system is in this country. This little boy that you see up here on the screen is the face of health care for me and my family. This is Tucker Wright. He lives in Malcolm, Iowa. His father, Brett, is my nephew. And when Tucker was 18 months old, he was diagnosed with liver cancer. He had 2/3 of his liver removed. He was lucky that he survived. But every day he has an ongoing lifetime medical challenge of survival. He continues to accumulate exorbitant medical costs, many of which are not covered by his insurance policy. His family has already incurred tens of thousands of dollars of uninsured medical costs. They hold fundraisers to try to raise the money that's not covered by their insurance policy. And his parents are both employed full-time and had what they thought was good health insurance. By the age of 20, he is 90% likely to have another form of cancer. He goes to Des Moines, Iowa every month to have expensive diagnostic imaging studies to monitor his health condition. And until we start looking at health care as this type of face and the faces that you present to us today, we're never going to get the American people to rally behind the need for comprehensive health care reform. Your voices here today, Tucker's face, and the people in this country just like him and just like you are going to be the unifying forces we need to transform health care delivery and the way we pay for it and the way we insure it in this country. And that's why I am personally so grateful that you took times out of your busy lives to help us put a human face on health care reform. And I yield back the balance of my time.
Thank you, Mr. Braley. Ms. Sutton from Ohio, opening statement, please.
Thank you, Mr. Chairman, and I too want to thank the witnesses for coming forward to tell us your stories, because with your voices you speak for so many Americans who are facing similar situations, and that's why we're so intent in this committee and in this Congress to make health care work for you and the people that you love and all of those out there who aren't in this committee room, but whose voice you bring by your presence. During the August district work period, I held many meetings with constituents, and I heard their views about health care reform. Among those whom I met with were Dash and Kathy Sokol in Lorain, Ohio. Dash just turned 56, and his wife, Kathy, is 53. In February of 2007, Dash was diagnosed with prostate cancer. And as he fought that cancer and he was fighting back later that year, Kathy was diagnosed with breast cancer. The Sokols had health insurance coverage through Dash's job at the steel mill. However, with Dash and Kathy both receiving treatment for cancer, the costs began to add up. Their out-of-pocket spending became overwhelming, and the Sokols are now using their pension funds to pay for their medical bills instead of saving those funds for retirement. Kathy told me that she felt guilty about having their family pay out-of-pocket for her cancer treatments in spite of the fact that they have insurance coverage. I want to repeat that. She felt guilty because their insurance plan did not provide adequate coverage. Many insurance plans out there today are far from adequate, and when the Sokols came to my office, they brought with them stacks and stacks of insurance invoices. They had bills, explanations of benefits and records of what they had paid for, in addition to explanations about why most of their treatments were not adequately covered. Dash showed me that aside from being sick, aside from emptying their savings, they also were keeping full-time records to make sure that they kept up with their payments as best they could. Dash has been working out arrangements with providers to pay what he can when he can. He tells them, "I'm willing to pay, but it will take time." He continues to work to make sure that they keep the inadequate coverage that they have. And in these uncertain economic times, he's concerned about whether his job will be there tomorrow. He told me that he'd like to retire, but is fearful of doing so before the couple becomes eligible for Medicare. And that if the job does go away, they worry, they live in fear about what will happen because they won't be able to get insurance, having had cancer. He could not imagine, he explained, what individuals who get sick without coverage do and how they cope. The Sokols came to my office to offer their story and to offer their help, just like you here today. They want to do all they can to make sure that meaningful, comprehensive health care gets passed. Dash told me when I asked about using his story to convey what they were experiencing, he said, "Absolutely. I'm willing to do whatever it takes." Well, I don't think that we in Congress should offer any less than what Dash is willing to offer, whatever it takes to pass meaningful health care reform. We have to do what it takes to make sure that American families are not spending their retirement funds just to stay alive. That is what far too many insured and uninsured Americans are facing. We have to do what it takes to hold insurers accountable for the benefits they promise us, and in many cases that people pay for. We have to do what it takes to pass health care reform this year. And I yield back.
Thank you. That concludes the opening statements by all the members of the subcommittee. We're going to stand in recess. We have 3 minutes remaining on this vote, and then we have another vote. Let's try to be back by 2:50, 2:55. And Tatum, if you want to join your father at the front table during the testimony, you're welcome to do so. Okay? We'll be in recess.
Yeah.